Hypercalciuria is the most common metabolic abnormality seen in stone formers, occurring in about 30 to 60% of patients. And it used to be classified according to the site of dysregulation, such as the intestine, bone, or kidneys. But those distinctions have been largely abandoned. And idiopathic hypercalciuria is a term we use for most patients because usually we don't find a disease necessarily, but more of a familial tendency to form stones, meaning a familial tendency to excrete more calcium in the urine than non-stone formers. Defining hypercalciuria is important as most in-house labs will give a cutoff value of 250 milligrams per day as the definition of hypercalciuria, and over 300 milligrams per day is the definition for men. However, these values may be too high as the risk goes up over 200 milligrams per day, as shown by some very good epidemiologic data, and this is clinical hypercalciuria. 24-hour urine has been scrutinized recently because of its complexity. However, it is currently the best test that we have. Other than hypercalciuria, you may find other metabolic derangements such as a low citrate or low urine volume that can be easily corrected. Idiopathic calcium stone formation without any identifiable source is usually found only in 3% of 24-hour urine, so I find that the 24-hour urine is very helpful. So this is a case of a patient with a medullary sponge kidney. She is 46 years old and has had recurrent kidney stones for quite a long time. As you can see by her CT scan, there are multiple stones in multiple areas of the kidney, and the stones were composed of calcium oxalate and calcium phosphate, which is typical. On her 24-hour urine, that shows 3 different 24-hour urines which have values of less than 250 milligrams per day, however, more than 200 milligrams per day despite a restricted diet. And it is not uncommon for these patients to have normal metabolic stone risk factors, but there is surely urine stasis occurring in the ducts, and if it's supersaturated, then crystallization is occurring. So reduction of that supersaturation is our main treatment goal. Medical management is important, as 50% of symptomatic kidney stone events could be prevented by addressing modifiable risk factors. There is a multi-component diet, which is normal calcium, low sodium, and low animal protein intake, and that has been shown to have a reduced risk of stone recurrence compared to just a low calcium diet alone. I will often prescribe a diet of 1,200 milligrams of calcium a day, which is a normal amount, as well as a low sodium diet. DASH diet has also been shown to have lower risk of recurrence, and it does have a high oxalate component, so patients with significant hypercalciuria, you have to be careful about that. If they continue to form stones despite this diet, they should be on pharmacologic management. So pharmacologic management can reduce recurrences, however, compliance is usually suboptimal. Thiazide diuretics are indicated with recurrent calcium stones and hypercalciuria. They do have some adverse effects to watch out for, such as hypokalemia, hyperglycemia, so periodic blood work should be checked. You may also see hypocitraturia. The potassium decrease can be significant, so I typically will place patients on either potassium chloride or potassium citrate, depending on their 24-hour urine. Indapamide is beneficial as it is dosed daily compared to hydrochlorothiazide, which should really be twice a day for kidney stone formers. Our second case is interesting. It's a patient who was on Topamax in the earlier 24-hour urines. And on Topamax, you can expect to see 24-hour urine changes that give a distal RTA-like picture with very alkaline pH and low citrate. And when the patient discontinued that medication, the citrate improved dramatically. However, the calcium level was quite elevated. So this case illustrates the importance of obtaining a 24-hour urine after making any changes. Our third case is a patient with a solitary kidney. He's 31 years old, and he has a lower pole calcium phosphate stone. On his 24-hour urine, there are several abnormalities, but you can see he has significant elevated calcium levels as well as an elevated sodium. So you can manage hypercalciuria with a big diet component. And the take-home point is that for every 100 milliequivalents of sodium that you go down, calcium should go down by 50 milligrams. With this patient and his degree of hypercalciuria, pharmacologic management will likely be necessary. Our fourth case is a patient who has had recurrent calcium phosphate stones for quite some time, and you can see on his 24-hour urine he has significant hypercalciuria in addition to low urine volume and low citrate. On his lab work, he did have an elevated serum calcium, as well as an elevated ionized calcium, low phosphorus, and a high normal PTH. And the main driver of PTH is really the calcium. It is the main control. So if the calcium is elevated and you have a high normal PTH, you should always be suspicious of hyperparathyroidism. 50% of stone events can be prevented, and the cost of stone disease is rising significantly. So anything we can do to prevent stone disease is important. And furthermore, patients with even asymptomatic kidney stones have been shown to have a worse quality of life. So if I find any abnormalities on the 24-hour urine, which we usually find in about 97% of cases, I will make either dietary adjustments, or if they have significant stone disease, dietary and pharmacologic adjustments. And I want to usually repeat that testing in about 6 months to see if any of the changes have made any effects and lowered their stone risk factors.